So today in this video, as you can see, I'm going to teach the basics of HRCT temporal bone. So what I'm going to do in this case is that I'm going to show you the basic anatomy of the patient's temporal bone, all the structures that are present within the different parts of the temporal bone, and whenever you operate for a case of complicated tympanoplasty or a modified radical mastectomy, be it cortical or canal wall up or canal wall down, you require a CT scan, right? But some people still out there do not know how to read a HRCT temporal bone completely. Also the basics they are not aware of. So in this video, I'm going to talk from a beginner's point of view, because a lot of people out there should understand the basic and the most easiest method to read a HRCT temporal bone. Okay, so what I'm going to do in this video is I'm going to talk about the anatomy from going from below to above. As you can see, this is the patient's HRCT in an axial view, and this is of a bony window. Now this is a window. I will not show the basic anatomy of the bone in a soft tissue window. That is completely wrong. So first point, if you're taking a HRCT of a patient, always ask for a proper thickness. Now this scan has a thickness of around 0.7 mm. I can see on the screen. I don't know if you guys can see. I don't think so, but it's showing 0.7 mm to me on the screen here. So the definitive thickness for you to understand all these structures out there is basically 0.7 on this scan. So it should be 0.5 to 1 mm basically. That's the ideal thickness, and you should be asking it for all three scans, that is the sagittal, axial and the coronal view. The best view is basically the axial and then the coronal. Okay, so that's it. So first I'm going to be talking about the basic anatomy from below above. So here we go. I'm going to zoom this for you guys. So this patient, what I'm having right now is a case of a skull-based osteomyelitis of the left side. So I'm going to go through the patient's normal anatomy on the right side, so that at the end of this video, all the students should be able to very easily identify the basic structures which you see in a HRCT temporal bone, okay, including the internal carotid artery, the jugular bulb, the sigmoid sinus, all the ossicles inside different parts of the temporal bone, that's the squamous and the petrous, and the relationship of the petrous to the clivus bone. Everything point wise I'm going to be covering up in this video. So let's begin. The first point, as I said, now the thickness I've mentioned, the scans, the views I've mentioned which are required, and this is a bony window, so always read the scan in bony window. First point, I'm going from below. So as you can see, now I'm just going to run you through this. So I'm going above. See, I was at the very low level. Now I'm going above. So at the very upper part, you can see the petrous part over here going to meet the clivus, and then you can see the brain. So I'm coming back at the very lowest part of the around the skull base, where the mastoid tip just begins. Okay, here we go. So I'm gonna zoom this. This is a maxillary sinus. You can see the posterior wall of the maxillary sinus, the septum, the inferior turbinate. Obviously that's the inferior turbinate because we're going from below above, so that has to be the inferior turbinate. Then this is the choana area, and that's the right side, and that's the left side. So as you can see, three structures. The first thing to remember when you start reading a scan is go from below above, and the very first structure you're gonna observe is a circular structure. You can see right here. You can just follow my cursor over here, and the second structure you're gonna see something like this, and very slowly as I keep on going above, you're gonna see the third structure right here. So I'm just gonna keep like this. So 1, 2 and 3, these three structures you're going to see very commonly in all the scans if you go from below to above. Okay, that's the first point, the first basic point you need to know, because I'm going to show you all the relations and simple points for you to remember this HRCT for a really long time. Okay, so first, this is second, and this is third. Now what are these structures? That's the styloid process basically. I'm going to show you the course of the styloid process as well. That's the styloid process bone, that's the mastoid tip over here, and that's the mandible basically. That's the ramus of the mandible, that's the body of mandible going up. So as we go up, the body of the mandible divides into two, the anterior one being the coronoid process and the posterior one being the condyloid process, right? The condylar process, that's the head of the mandible basically, which fits inside the temporomandibular joint. So these three structures are going to come first. So remember all these three structures. Now as we are going up, just pay close attention. That's the styloid process. Now we all know the styloid process from above downwards runs from lateral to medial, right? So now as we go up, this thing is going to come medially, and the mastoid tip is in visualization over here, and we're going to start seeing the mastoid air cells in the mastoid tip. So here we are going above, slowly you can see the pneumatization of the mastoid air cells, and that's the trabecular network. You can see multiple mastoid tip air cells, and this is the styloid process, which is going to slowly shift medially. So if I go very below, you can see the styloid process is way medially, and as we keep on going up, now I'm going up right now, you can see the styloid process is going medially and eventually coming near the mastoid tip, where you can see the stylomastoid foramen somewhere over here in this area where the facial nerve exits outside, which I'll show you in the coronal view as well. So this is the relationship between the styloid and the mastoid tip. Now we are going above. So as you can see, the body of the mandible is disappearing over here, and we can see two processes. That's the condylar process, that's basically the posterior one, and that's the head of the mandible right now, which is going to fit in the TM joint. So now I'm still going above. So I'm going above. You can see much more mastoid well pneumatized mastoid air cells, and the styloid process is gone right now. It's not visualized anymore, but what you can see right here is the mandibular head. Then later on, as we keep on going up, this mandibular head is going to form the temporomandibular joint. You can see the bone above here in some time, and you can see the mastoid air cells over here. So three structures, you remember, follow these three structures going above, and then slowly you're going to start having the external auditory canal into picture. So the first three structures are the mastoid tip, the styloid process, and the ramus and the head of the mandible forming the temporomandibular joint. These three structures, if you keep going above, you're going to see the mastoid air cells, and slowly concentrate. The next fourth structure which you're going to concentrate on is the EAC. So as we keep on going above, you can see these two structures coming into view. I'll explain after some time, just a while, what these two structures are. But for them to have a landmark, I need to expose and show you the tympanic membrane over here. So now you can see that's the complete external auditory canal over here. You can see that's the membranous external auditory canal, and that's the basically bony external auditory canal. So we have two parts in the EAC, right? The outer one is the cartilaginous, and the inner one is basically the bony one. So you can clearly see that's the bony one, and that's the cartilaginous membranous one. Okay. So once you expose or visualize the EAC, still keep on going above. You can slowly start seeing the tympanic membrane right there. So this is a faint structure you can see over here, right? That's the tympanic membrane right there. Now remember, this is the axial view, so you're going to see a slant view of the tympanic membrane. Also, you're going to see a slant view of the tympanic membrane on the coronal section as well. Okay, so you can see a faint structure over here. That's the tympanic membrane, clearly seen on your screen. And you can see the temporomandibular joint. Now you can see the fossa over here. That's the TM joint on the right side. That's the EAC, the cartilaginous one, and the bony one. You can see the mastoid air cells over here. Now, once you've visualized and located the tympanic membrane, always take this as a landmark. And these two structures now, which you can see over here exactly like finger-like projections over here. The one above, you can see that is one anterior. So this becomes anterior and this becomes posterior because it's an axial scan. The one above over here is the internal carotid artery, and the one over here is the internal jugular vein. So this is a jugular fossa or the jugular bulb, and that's the ICA. Now always remember, you have to find the EAC for that, and you have to locate the tympanic membrane. Once you see the tympanic membrane, you're going to properly see these two structures right next to each other, like anterior and posterior. That's the internal carotid artery, and that's the internal jugular vein, that's the jugular bulb. So in cases of high rising jugular bulb, you get a lot of cases where there's a high rising jugular bulb. So you can see that's the proper bony cortical covering over here. So there is no dehiscence as such. A lot of cases may have a dehiscence, may have a high rising jugular bulb. You can see this is not the case in this condition. So it is properly in the lower aspect, and you can properly operate in cases of such situations. So these two structures, after visualizing the tympanic membrane, you have to keep that in mind. And now I'm going to follow these two structures only for some time. That's the mandibular joint over here. So I'm going to go above. So I'm going above. Keep your attention on the internal carotid artery, and then later on the IJV. So now I'm going to show you 3 to 4 structures more, keeping the internal carotid artery as the landmark. So as you can see, the course of the internal carotid artery is changing here. So I'm going to show you the course of the artery. So this is a place where I can start seeing the internal carotid artery. It is the place where the artery is entering vertically from the neck, that is the parapharyngeal area, into the skull base. Okay, so we all know that the carotid artery has different routes, and I've done a video on the course of the internal carotid artery. So the very first part being the cervical segment, it exactly vertically ascends upwards into the carotid sheath along with the IJV and enters through the skull base, that's the carotid canal. Once it enters the carotid canal, it runs for a short period vertically and takes the first turn inside the petrous temporal bone, then becomes the horizontal carotid, which I'm going to show you right now. So this is a vertical carotid right here, the short vertical. As I keep on going above, this is still the vertical, and now you're going to see it takes the first turn. As you can see, that's the genu of the carotid, and this is the horizontal one. That's the horizontal segment, still in the petrous part of the temporal bone. Okay, so we have a course of the carotid within the petrous temporal bone, and then later on this horizontal forms one more genu. Now I'm still going up. You can see the proper horizontal segment over here, and then I'm going to keep on going up. I'm still going up, and you can see now it's going to convert into an exit from the foramen lacerum over here, and also have a short vertical segment before it enters into the clivus and becomes the paraclival carotid. Okay, so here it's gonna ascend up. You can see that's the clivus bone over here, and you can see the carotid artery has become vertical again. So it's gonna ascend along the clivus bone to become the paraclival carotid, and then later on it's gonna enter into the cavernous sinus as we keep on going up. Okay, so this is how the course of the carotid, and later on the intracranial cavity as such. So coming back again below, so once you can see the genu of the carotid, so just before that, that's the beginning of the horizontal segment of the internal carotid artery. Now 4 more structures of the temporal bone, remember, keeping this as a landmark. So when the carotid artery, you can see the carotid artery is taking a turn over here. You can see a bone over here. That bone represents the middle ear, and that is basically nothing but the so see, I'm going up. Now this bone is basically the promontory in the middle ear. So when you open up during tympanoplasties and MRMs, when you lift up the annulus, you see a huge bulge in the middle ear, right? That's the promontory. You can see that's the EAC, that's the tympanic membrane area. Once you lift it off, you can see a bulge over here. That's nothing but the promontory, that's the cochlea. And you can see now I'm going up again. This is the carotid, still the horizontal part. Now you can see that's the cochlea, basically cochlea. That's basically cochlea. The grayish part, which you can see over here, it's the basal turn of cochlea. So keeping the carotid artery as a landmark, just posterior to that, you can see a bone which is the promontory, the bulge of the basal turn of the cochlea in the middle ear. That's the cochlea which is starting, and that's the basal turn of the cochlea. So the first structure, keeping the ICA as a landmark, we saw that this is the basal turn of the cochlea. Okay, now keeping this basal turn of the cochlea as a landmark, what is this structure which you can see over here? Always remember the structure. You saw promontory, and what is there behind and below the promontory? Okay, it is basically the round window. So what is this? My arrow is pointing out at the round window area. Okay, this is the round window. And what is this bony projection over here? That's the round window niche. Okay, that's the round window niche basically. So keeping the ICA as the landmark, the course of the ICA we studied right now, this is the promontory, that's the cochlea. Moment we see the basal turn of cochlea, you see this is the round window, and that's the round window niche. That's the bony projection which covers up the round window opening. Now, so this is the basically ICA, the cochlea, the basal turn, and the round window over here. Now this is the IGV, that's the jugular bulb, that's the jugular fossa. You can keep on following that. I'm going up. This disappears right now. Okay, so this is the place where you can see the jugular bulb. So we going from below above. So the jugular bulb is below, the carotid is below, and this area you can see over here, that's the sigmoid sinus, the very far lateral, that's the sigmoid sinus. So as if you're doing an MRM out there, the most posterior structure, the most posterior structure, once you're drilling, and you can see that's the outline of the sigmoid sinus. We got to be careful with this sinus. If you puncture this bone and there's bleeding, you have to use a lot of hemostatic methods to make the bleeding, to stop the bleeding. So this is a sigmoid sinus area. So on a CT scan, the sigmoid sinus is on a very lower aspect. So on the lower aspect, we have three structures: the sigmoid sinus, the IJV, that's a jugular fossa, and the internal carotid artery. The round window, we can see the round window niche over here, and the basal turn of the cochlea. So are we going up? This is a basal turn of cochlea. Now, these are the three structures we just saw, and I'm still going up. I'm going to go up. So there are two structures more which I have to show you guys. Okay, so as you can see, once we located the EAC, that's the cartilaginous EAC and the bony EAC, and once you localize the tympanic membrane, we had located the ICA and the IJB, right? At the same plane or the same time, you can see these two structures over here. This one opening, huge circular opening, and this one smaller one. This is basically foramen ovale, and this is basically foramen spinosum. Okay, that's the TM joint, that's the foramen ovale, that is ROS. So we cannot see the R right now here, I don't know, but we can see the ovale and the spinosum. Okay, so this is one more point you have to keep in mind. So as I'm going above, we saw the ICA taking a turn, the gaining of the horizontal part. Petrus, this is the basal turn of cochlea, the round window. You can see a glimpse of the ossicular over here. Now slowly you're gonna see two complete lines, one next to each other, this one being the malleus, and the next one which appears as we keep on going up will be the incus. So this is the malleus, this is the incus. You can see the two dots over here. This is the cochlea. Now I'm going to talk about the mesotympanum, the contents, that is the ossicles, at a later point. But now I'm going to be talking about the complete anatomy of the inner ear. That is the semicircular canal, the orientation, the division of the semicircular canals, how the vestibule is formed, how the cochlea is formed, the turns of the cochlea, along with the IAC, that is the internal acoustic canal, along with the Bill's bar and the crista falciformis, and the 7th, 8th nerve complex, and the vestibular nerve. Everything I'm going to show on the scan. Okay, also the cochlear aqueduct and the vestibular aqueduct. So the second thing, as you can see over here, once we had visualized the tympanic membrane right here, we saw that there was the ICA and that was the IGV. Now, as we keep on going, I need to show you guys the the cochlear aqueduct. See, this was the IGV ICA. You keep on going above, that's the basal turn of the cochlea. See, the moment you visualize the basal turn of the cochlea exactly in line below, you can see this projection of the bone inside. That's the cochlear aqueduct. So the moment you visualize the cochlea from below above, the basal turn of cochlea, you see the cochlear aqueduct. So this is the point you have to remember. So that's the cochlear aqueduct just right next to the IJV, the jugular fossa, the jugular bulb right there. Okay, so going below to above, now we can see that's the basal turn of cochlea. We're going from below to above, always remember that. That's the basal turn of the cochlea. The biggest turn is the basal turn, always remember that. Then we can see the middle and the apical turn coming into picture right now, and then we can see the vestibule over here. This separate opacification like of a structure you can see over here, that's the vestibule. And this structure now, which you can see, I'm just going to zoom this for you guys. This is vestibule over here, which will correspond to the area of the oval window, and that's the ossicular. And sometimes you can see the in some time you're going to see the stapes over here, but that later on I'll cover in detail after some time. So this is a vestibule area, remember this for now, that's the vestibule. And this entire thing is the cochlear apparatus. Okay, so if I'm keeping on going above, you can see the cochlear the modulus of the cochleus. This is 1, this is 2, like a club sign, right? Like a club leaf sign. So that's the cochlear aperture, and that's the modulus of the cochlea, and that's the vestibule still over here, and that's the glimpse of the internal acoustic canal you can see from below above. So I'm still going above, and here you can see the appearance of the lateral semicircular canal. Okay, that's the lateral semicircular canal, that is a signet ring shape. Basically you can see the actual signet ring shape. So we all know that the semicircular canals open up in the vestibule, right? All the semicircular canals open up in the vestibule, we all know that. So you can see that's a signet ring shaped lateral semicircular canal, and you can see a glimpse of the facial nerve over here. So once I talk about the entire anatomy of the labyrinth, that's the inner ear, that's the cochlea and the vestibule. Once I'm done with that, I'm going to talk about the mesotympanum and the ossicular anatomy in complete. And then later on, as a separate segment in the same video, I'm going to talk about the entire course of the facial nerve as well. Okay, on this very scan. So that's the signet lateral semicircular canal. This is still the cochlea. That's the termination of the cochlea as we keep on going above. And this is the glimpse of the IAC. As we keep on going above, you can see that's the internal acoustic canal coming into picture right now, and this is the proper internal acoustic canal. And still we are going up, you can see the entire internal acoustic canal right there. So what is the significance of the internal acoustic canal? Now, as we all know, it has the 7th and the 8th cranial nerve and the superior and the inferior vestibular nerve. Okay, so we all know that there are 4 quadrants in the internal acoustic canal from below above. So it's anterior, superior, anterior, inferior, and posterior, superior, and posterior, inferior. So see, as we are going, this is an axial view, and we are going from below above. The first structure we'll see is the inferior vestibular nerve and the cochlear nerve. Okay, this is very common. So from below above we are going right now. So the very first structure we're going to see is the cochlear nerve. So I'm going to show you the cochlear nerve right now and the vestibular nerve. But before I do that, I want to show you this structure. You can see the clear modulus of the cochlea. This is the cochlear aperture. You can see a thin bone over here, the segment of bone. This bone is the bone which separates the internal acoustic canal from the cochlea right there. So this has a huge significance in cases of cochlear implant. If the bone is not there, it's going to have a gush of CSF leak and all those complications you can see over here. That is the during the cochlear implant, basically some kind of a deformity which is called, I don't know, the IP3, I guess. So I'm not much into cochlear implants, but still I see the videos. So you can see that's the IAC initiation over here, and that's the lateral semicircular canal. That's the facial nerve going under the lateral semicircular canal. So I'm going to follow the cochlear nerve. So the cochlear nerve basically exits from this cochlear aperture, okay? And you can see at some point, you can see a connection between this area and the vestibule. So you can see a connection between the internal acoustic canal. You can see a faint grayish color communication over here. You can see that's the entry point of the vestibular nerve, which is in connection with the vestibule and from the IAC. So the cochlear nerve enters from this like this, and the vestibular nerve is entering from here. So from a level which is below, you're going to see the inferior vestibular nerve and the cochlear nerve. Okay, so if we keep on going above, now you're going to see the facial nerve. That's still the canal and the vestibule over here. So as we know, we saw the cochlear nerve right there along the cochlear aperture near the modulus. We saw the inferior vestibular nerve. Now as we going above, we can see the facial nerve. Okay, and you can see this structure over here. That's basically the labyrinthine segment of the facial nerve right there. I'll just show you. So you can see that's the labyrinthine segment of the facial nerve. That's the genu, the first genu of the facial nerve right there, and it continues as the tympanic segment. You can see that's the tympanic segment of the facial nerve. If we go above, that's the tympanic segment of the facial nerve. That's the modulus right there. So as we're going above, you can see a small turn over here. That's the genu of the facial nerve, the first genu. We're still going above. You can see a segment over here in the internal acoustic canal. That is basically the labyrinthine segment of the facial nerve, where it takes a turn and then it continues as a tympanic segment, which you can see right here. Okay, that's the tympanic segment. So this is how the facial nerve exits the internal acoustic canal and travels into after the genu and the tympanic segment, and then later on becomes vertical. So the tympanic segment is basically a horizontal segment, and then in the mastoid it becomes vertical and exits from the stylomastoid foramen. Okay, so this was the basic anatomy of the cochlea, the turns of the cochlea, the cochlear aperture, the cochlear nerve, the IAC. You can see the exit here over here. This is for the vestibular nerve, the superior and the inferior vestibular nerves, the vestibule over here. So this is basically the IAC, the cochlear and the vestibule. Now coming back to the ossicular anatomy. Now for that I need to go very below at a lower level. So okay, fine. So this is the EAC which we saw, the bony EAC, and going above you can see the tympanic membrane right there. So we all know the middle ear has got three parts. That is the epitympanum, mesotympanum and the hypotympanum, which I'm going to show you much more clearly in the coronal view. But for now, at least, you're going to see the anatomy of both the epitympanum and the mesotympanum for sure. So I'm going above. So there's one more thing before I proceed on to the ossicular anatomy, is that if you remember some time back, I mentioned the point that once you locate the ICA, that's the ICA, you start seeing the promontory right there, right? This is the promontory, and that's the first basal turn of the cochlea, the first appearance of the cochlea. That's the basal turn right there. That's the round window, okay? And that's the round window niche, okay? So once you locate this, near the internal carotid artery, you're going to see a structure which is full of air, which is black. This, which I'm pointing on right now, is the Ischemian tube. Okay, so carotid artery is in close relation to the Ischemian tube in the middle ear, as well as behind the fossa of the Rosenmuller. The Ischemian tube is in close relation to the carotid artery. So this structure is the carotid artery, this one, and this is the Ischemian tube right there. So as I'm going above, there is one more structure which is in close relation to the Ischemian tube. That is the tensor tympani muscle. You can see something similar, just like facial nerve. Now, a lot of students may confuse this for facial nerve, but this is not facial nerve. This is basically ischion tube, and the structure which is in close relation to the ischion tube is the tensor tympani, as you can see right there. So this is the ischion tube, and this is a tensor tympani muscle right there, and you can see the tensor tympani right there. Okay, so while in the semicircular canal, there's one more point I need to show you. So I showed you the basal turn of the cochlea. Okay, then as we go up, this becomes the vestibule over here. This is the cochlea, the apical, and the middle turn. That's the vestibule. That's the IC. So we saw the lateral semicircular canal as well. That's the facial nerve going under the lateral semicircular canal. Also, I need to show you the superior semicircular canal, as you can see. So from the very below, we could see the basal turn of cochlea, somehow then dividing into the vestibule over here, and that's the cochlear turns over there. And this is the lateral semicircular canal. Okay, and then as we go up, you can see the two snake eye appearances. Now I'm going to go from above downwards to make you understand the anatomy of the semicircular canals. Now if you're reading the HRCT scan from above below, okay, listen very carefully. If you're listening, if you're watching the HRCT temporal bone from above below, so it's gonna be looking somewhat like this. So I'm going from above below right now. So it's gonna look like a snake eye appearance. You can see the two dots. The most above scan will show a straight line like this. That is the superior most part of the superior semicircular canal. And now as we keep on going, now we're going below. Okay, so as we go below, it becomes into two. So as you can see, the semicircular canals have, this is a superior semicircular canal, giving a snake eye appearance. And this is the ampillated end, and this is the non-ampillated end. Now the semicircular canal, the superior one, the ampillated and the non-ampillated. So the non-ampillated of the superior semicircular canal comes in connection with the non-ampillated of the posterior semicircular canal. So if I'm going down, you're gonna see this one coming in contact with the posterior semicircular canal right there. You can see this is a posterior semicircular canal into picture right now, and if I keep on following that, you can see that's the posterior semicircular canal below now. So this was the common opening. This was the posterior semicircular canal. This was its end, and you can see if now I'm going above, you can see this is a non-ampillated end of the superior semicircular canal. And if I go below, you can see that's the posterior semicircular canal into picture there, and it's having a common opening. Now, so this structure which you can see right there, now this is a posterior semicircular canal. The entire thing is a posterior semicircular canal. I'm going to keep on following that. You can see, you can follow my cursor. That cursor is showing the route to the posterior semicircular canal all the way. So that's the posterior semicircular canal. Again, you can see that's the posterior semicircular canal right there. It ends. Now it disappears. So that was the entire course of the posterior semicircular canal. And we already saw the lateral semicircular canal, which was like a ring, signet ring shape. We saw the superior semicircular canal. So all the three canals we saw, and we saw the entire labyrinth, the internal ear structure. Now we're coming on to the ossicles. So once you visualize the tympanic membrane and the base turn of the cochlea, you start seeing a single white structure over here. You keep on going above, you see the long process, that is basically the handle of malleus over here. You keep on going above, you can see the second dot over here, that's the incus basically. And keep on going above, you can see the long process of the incus basically. And then if you keep on going below, that's the lentiform process of the incus. And then you can start seeing the stapes over here. Let me zoom this for you. You can see that's the crura of the stapes, very clearly seen. Now this entire thing is mesotympanum. Okay, this entire thing is mesotympanum. you can actually see the crura of the stapes. And sometime back I told you that this structure is the vestibule, right? So vestibule corresponds to the area of the oval window, and as we all know, the stapes footplate sits on the area of the oval window. So it's very easy. First, localize the tympanic membrane. So this is how you locate the tympanic membrane. You can see that's the EAC over here. That's the bony EAC. That's a glimpse of the tympanic membrane right there. And once you see the tympanic membrane, obviously you're going to see the malleus being attached to it. So you can see the first structure as soon as the basal turn of cochlea comes into picture right there. That's the handle of malleus basically, and then you can see the incus over here, and then you can see the long process of the incus over here, and then that's the lentiform process of the incus in connection to the stapes head. And then in the next image you can see that's the crura of the stapes clearly seen, and that's the vestibule area. That's the vestibule, and this area is the area of the oval window. Okay, now one more structure you can see over here. Now, as we all know, I'm going to zoom this further up for you. Now pay very close attention to my mouse, the cursor over here. As you can see, that's the stapes head area, and we all know from the stapes head and the neck region we have a stapedius tendon. You can see actually a small opacification over here. That's the stapedius tendon right there, and you can see this is a pyramidal eminence. You can actually see the W shape. Follow my cursor. So this is the W shape over here. The moment you see the stapes, in cases of mastoidectomy surgeries where you see the patient is having a lot of cholesteatoma, a lot of chronic mastoid infection, a lot of opacification in there. So and in certain cases you are not able to see the stapes completely absent because of the necrosis happening inside. So how can you locate the stapes then, or how can you locate the vestibule, or how can you locate the anatomy of the facial nerve or the facial canal? So the very simple method is that no matter what, in the most severe cases of cholesteatoma or mastoid infections, the internal ear is rarely affected. Trust me, the internal ear is rarely affected. So you're going to go and look for the vestibule and the cochlear apparatus. So you're going to have a look on the vestibule. So near the vestibule opening, you will see the oval window area, and you can just assume that this could be the area of the stapes, and you can see something like this. Now this area, you can see a dip down there. This area, that's the second limb of the W. This is sinus tympani. So the moment you see vestibule, the oval window, and the stapes, you're going to see something as W, and the second limb over here is the sinus tympani. The middle limb over here is the pyramidal eminence, for which you can see the stapedial tendon attachment, and the first limb over here is the facial nerve. That's the facial nerve. So later on I'm going to tell you in detail about that. So that's the facial nerve over there. So always remember this. So we saw all the structures: the oval window, the round window niche, the round window, the sinus tympani over here, the pyramidal eminence, the facial canal, the vestibule, the cochlea, the stapes, the ossicles. So if I keep on going above, you can now see, now all this was basically the mesotympanum area, right? Now I'm going above. So what is there above the mesotympanum? We all know it's the epitympanum, right? So now I'm going to go show you the epitympanum, and with which you can see the ice cream cone appearance right here. So you can see that's the proper ice cream cone appearance, and you can see this entire structure over here is the epitympanum. This is basically the additus ad intrum, and this is basically the intrum. So we all know whenever you're performing a mastoidectomy surgery, we all perform surgeries, we all have performed MRM surgeries. We all know we drill the mastoid bone in the McEwan's triangle, right? And we go deep down and we see a huge opening. So we just have a giveaway, and we are all happy to see that huge mastoid cell, which we all call as intrum, right? So this is that intrum, the largest, most mastoid air cell. That's the intrum. You can see it's a huge one. And so this is the epitympanum, that's the additus ad intrum, and that's the mastoid intrum here, the largest mastoid air cell. So this is the mastoid air cell which you encounter while drilling in the mastoid surgeries. So if there is any cholesteatoma or any granulation tissue or chronic mastoid infection cases, this connection or ventilation is blocked off. And because of this, there is no drainage, there is no ventilation. So you have to do an agitus opening, and so that you can have access to the antrum and have a patency achieved. Okay, so the structure which is present in the epitympanum, that is the attic basically, is the ice cream cone, right? Now, what structure of ossicle forms the ice cream cone? So we all know this is the head of the malleus over there, the one above, that's the head of the malleus, and this is the incus body part and the short process of the incus. So the long process will come down in the middle ear, in the mesotympanum, which is attached to the stapes head, and the short process of the incus is basically present in the epitympanum. So this is basically the ice cream cone appearance. That's the antrum, and if we still keep on going above, you can see the mastoid air cells, and in some the tegment tympani and the tegment mastoidium I'll show you much better on the coronal scan. Okay, so this was the anatomy of the ossicles basically. Now I'm going to show you the anatomy of the facial nerve. Now let me just zoom this out. So the most important thing in cases of accidental trauma, iatrogenic injury, the facial canal holds a very huge important place. Now, how do you find the canal? How do you find the facial nerve is a huge issue, right? So I'm going to give you an easy landmark to follow the facial nerve. So we saw the scans from below upwards, right? So let me just show you. So this was the lowermost area right there. That's the lowermost area. So as we come up, you're gonna see the tympanic membrane. You're gonna see the ICA, the first basal turn of the cochlea. You're gonna see right here. As soon as you see the cochlea, you see the round window. You keep on going up. You keep on going up. You're gonna see the stapes over here. Then this is the sinus tympani, and there you can see the glimpse of the facial nerve. That's basically the mastoid part of the facial nerve going vertically downwards to exit from the foramen. And then as we keep on going up, now I'm going up, follow my cursor, that's the facial nerve. Now you can see that's the horizontal tympanic segment over here. And then if I keep on going up, see, that's the lateral semicircular canal. We all know that the facial nerve runs below the lateral semicircular canal. Okay, the facial runs below the lateral semicircular canal. And as we keep on going up, you can see that's the tympanic membrane. That's the labyrinthine segment in the ISC. That's the labyrinthine segment, and that's the first genu. Then the horizontal segment, and that's the horizontal segment, and then another genu over here to make it as a vertical mastoid part, and then the exit from the foramen. So this is how you basically look for the facial nerve in cases of decompression surgeries, or in cases of facial recess approach, or in cases of accidental traumas where you have to decompress the facial nerve. Okay, so this is the basic anatomy, the basic points which you need to look for, okay, in an axial scan for the HRCT. Now I'm going to go on the disease side. Now, as I told you before, this is a patient of skull base osteomyelitis. This patient is having a lot. I'm going to keep the two sides for comparison, and I'm going to just in the next 5 minutes cover up the diseased part as such. Okay, so you can see this is the normal side, and that's the affected side. So this is basically a tilted scan, so you're not going to actually see a real-time differentiation over here because this side is tilted. You're going to see that after a little bit of time. So going on the very below aspect, the most lowermost part, as you can see, this is basically the styloid process. That's the ramus of the mandible. So as we go up right now, you can start seeing the mastoid tip over here, and that's the styloid process. That's now the head of the mandible. That's the condylar process. And as we keep on going up, so the first three structures are the head of the mandible, the ramus, the mastoid tip, and the styloid process. So as we keep on going up, normally the next thing we should be looking for is the EAC. Here you can see that's the EAC, and slowly if we keep on going up, you can see that's the bony EAC, but that's a positive thing. You can actually see there is a huge dehiscence in the bony canal over here. A little bit of dehiscence over here, but a huge dehiscence. You can see gaps of bone over here in the bony part of the EAC over here. So that is the dehiscence you can see over here because of the chronic infection and the skull base osteomyelitis over here. Now, if you can compare on this side, you can already see the cochlear modulus of the cochlear aperture. But here we are just seeing the EAC. So you can imagine how much of a tilted scan this is. So we already see the cochlea on this side and only the EAC on this side. So if we keep on going above here on the left side, you can see a soft tissue shadow in the middle ear. That's the soft tissue shadow in the middle ear. And we can see the carotid artery, the horizontal carotid right now on the left side. And this is the promontory bone. You can see this is the middle ear and it's fully ossified. That's the middle ear. Here I am not able to see the tympanic membrane much clearly, but I can see that this is a middle ear and that is fully ossified right there. So to find this is a sigmoid sinus area on the left. This should be the area of the the jugular bulb right there. This should be the jugular bulb, and you can see that's the promontory over there. That's the promontory. That's the horizontal part of the ICA. That's the cochlear aqueduct. So we should be seeing the basal turn of the cochlea right in some time. So this is the basal turn of cochlea we see right there. That's the basal turn of cochlea. This is all the ossified material over here. You can compare fully pneumatization over here and complete ossification of the mastoid air cells on this side. You can see all the mastoid cells are basically ossified. There is not a single pneumatized cell on this side. This is the basal turn of the cochlea. As we keep on going above, this is a basal turn. This is the middle, and then the apical turn. This is a vestibule right now. You can see that's the vestibule, and this is a modulus. You can see that's the IAC. That's the vestibule right there. And once you see the vestibule, this should be rough. This is a posterior semicircular canal in picture right now. This is the vestibule, and I think this is the area of the oval window. You should be able to see the stapes right there, but I'm not able to see it. If I can zoom this, you can see that's the cochlear modulus, that's the cochlear aperture, that's the cochlear nerve, that's the IAC, and that's the vestibule, that's the posterior semicircular canal. This should be basically the area of the stapes, but the stapes is not visualized because of the ossification in the middle ear. This should be the ossicule, the malleus, and the incus is right there. If we still keep on going above, you can see that's the posterior semicircular canal, that's the vestibule area. You can see the labyrinthine segment of the facial nerve taking a genu, and that's the tympanic segment of the facial nerve. That's the malleus, that's the incus. That's the lateral semicircular canal. So if you're not able to see the facial canal because of the excess disease in a particular side, you just have to expose the lateral semicircular canal, and below that lateral semicircular canal you can see the facial nerve passing through. So that's the lateral, that's the superior semicircular canal, that's the posterior semicircular canal right there, and that's the posterior right there. You can see that's the posterior canal. That's the non-ampullated end of the superior meeting with the non-ampullated end with the posterior and making a crus commune right there. So that's the patris apex over here. Basically, now I'm going below again. That's the lateral semicircular canal. That's the superior semicircular canal. That's the posterior semicircular canal. That's the cochlear modulus, IAC, cochlear nerve. This area is the vestibular nerve. You can see an opening right there. That's the vestibular nerve. This area should be the area of the facial nerve above. So if we go above, this is the facial nerve. You can see a glimpse of facial nerve right there. That's the glimpse of the facial nerve. That's the tympanic segment of the facial nerve. That's the labyrinthine segment right there. And that's the genu. So that's the facial nerve right there. The stapes is basically not visualized, although you can see the ice cream cone appearance right there. That's the malleus, that's the incus body, the short process. That's the epitympanum. So if you remember the epitympanum on this side, now I'm going to compare the epitympanum on this side. You can see in some time. You can see that's the epitympanum, the ice cream cone appearance on the right side, and I can see it's highly pneumatized. There is not a single soft tissue shadow or liquid collection or any disease over here. And if you can compare the ice cream cone appearance on this side, you can see that's the ice cream cone appearance on the left side, and I can see it's completely opacified. It's completely full of either some kind of liquid or pus or some kind of soft tissue, but definitely this is completely non-pneumatized, not even sclerotic. It's completely diseased mastoid, right from the above superficial superior area to the mastoid tip. Each and every mastoid air cell is opacified. You can see that each and every mastoid air cell is under opacification. Not a single pneumatization or ventilated air cell is there. You can see a lot of dehiscence. You can see also, we can see dehiscence on the carotid canal in this case. Now if you can just pay close attention to the carotid canal, you can see a dehiscence in this area. You can actually see a break in the bony covering of the carotid canal at the turn of the genu, where it becomes the horizontal segment. You can see this is the dehiscence right there, and because of this dehiscence, the patient was having a lot of pulsations, as I showed in my last video. The exactly last video to this one is the patient was having a lot of pulsations in the tympanic membrane is because of this. So the middle here is full of soft tissue. You can see this is full of soft tissue. Tympanic membrane is somewhere here. Because of the dehiscence directly behind this, the soft tissue was transmitting all the pulsations inside onto the tympanic membrane, giving a false appearance of a vascular tumor behind. Okay, so you can see that this patient also had reported foramen ovale dehiscence as well. So now where to find the foramen ovale, I'll show. This was the styloid process right there, and this is the mastoid tip, and this is a ramus. So if we go above now, you can see some foramen appearing over here. The foramen, it should be foramen ovale. That's the foramen ovale on the right. That's the foramen spinosum on the right. We should be seeing now, this is a foramen ovale somewhere. Should be somewhere here. You can see some sclerotic bones there. This should be the area of the foramen ovale and the foramen spinosum, but then there is some kind of sclerotic bony changes happening there. So this could be the area of the affection. So this is how a diseased side looks like. It's very difficult to clearly visualize the facial canal or the ossicle, the stapes. However, we do require a mastectomy for this patient to have a proper ventilation between the agitus and the atrium. So this was all the basics about the temporal bone. Basically, in an axial view, coronal view, I'll just make sure I show it to you very quickly. So as you can see, this is a coronal. Now, if you have been handed a coronal section of the HRCT temporal bone, always remember there's a few landmarks where you can start the scan from. So the very first thing you gotta focus on is the mandible, the TM joint. So the first thing you see, if in the exams you're given the temporal bone for your spotters and you're given a coronal view, always remember that. Always first of all visualize the TM joint, and from the TM joint you can proceed behind. Okay, this is a coronal view. So the first structure you see is the body of the mandible. That's the condyloid process, the TM joint over here. And the second structure you see is the internal carotid artery. This structure you can see over here is the ICA. That's the ICA, and keeping in mind the ICA, you can keep that as a landmark. If you go behind, you can start seeing now the second structure you need to see is the EAC. That's the external auditory canal. Now remember, this is a tilted scan, so the patient is having a right side tilt, so the EAC will be visualized a little bit late and the ossicles will be visualized a little bit early. So keeping that in mind, we can see that's the tympanic membrane. You can see a faint hue of the tympanic membrane right there. Now, we all know the superior attachment of the tympanic membrane is called as the scutum. You can see the bone over here. This bone is called as the scutum. So in cases of cholesteatoma or chronic retraction pockets, or where there is attic destruction, there is always the radiologist will be reporting as whether or not the scutum is eroded or dehiscent. So this is a part which you call it as scutum, where the tympanic membrane is attached. You can see that the tympanic membrane is attached over here. That's the EAC. This is the middle ear cavity. You can see that's the external ear. That's the middle ear. There you can see it. That's the if I can just zoom that and go behind. Okay, so that's the scutum, right? I need to show you the Prusac space. So you can see the ossicle over here. I need to show you the malleus right there. Okay, so this is a very initial scan. Now you can see the malleus over here. That's the scutum, okay? And that's, so the space you can see between the malleus, that's the ossicle over here, and the scutum above in the epitympanum is called as the Prusac space. So if I zoom this for you, this is the EAC, that tympanic membrane you can see over here. That's the scutum, that's the bony projection for which the attachment of the tympanic membrane takes place. This is the epitympanum. Above this is the epitympanum. This is the mesotympanum, and below this we'll be seeing the hypotympanum. You can see the anterior process of the malleus. This is the anterior process which is attached to the tympanic membrane. That's the head of the malleus. That's the scutum. The space between the malleus and the scutum over here is the Prusac space. This is the tympanic membrane. That's the middle ear mesotympanum. This is the epitympanum right there. So if we go behind, you can start seeing this is the incus. This is the incus in picture right now, and you can see the stapes over here, the lentiform process, and that's the incus basically. This is the incus bone. That's the stapes bone, and this area over here, you can see this area is the area of the oval window and the stapes footplate. So this is basically, this is the incus. That is the area of the oval window where the stapes footplate will be present. Now this is the bony projection, that is the promontory, that's the basal turn of the cochlea, and above here this is the vestibule. As we all know, the vestibule opens into the oval window, and this is the internal acoustic canal. You can see the crista falciformis right there, dividing the internal acoustic canal in the superior half. That is the cochlear nerve. Sorry, not the cochlear nerve, the facial nerve. That's the facial nerve canal over there, and below will be the cochlear nerve. Okay, so there is anterior superior is the facial nerve. This is the anterior superior facial nerve. That's the anterior inferior. That's the cochlear nerve. That's the basal turn of cochlea. That's the promontory right there. That's the oval window right there, and below here would be the area of the round window. So if we keep on going behind, that's the vestibule in the center. This is the oval window. That's the basal turn of cochlea. Now you can see some two projections over here. Like some people, radiologists keep on mentioning this structure as a mermaid's tail, but it's more looks like a crocodile's mouth, basically, with the jaws open up. So the longer above, the upper one is the superior semicircular canal, and this one is the lateral semicircular canal. So this is a vestibule. We all know the canals open up into the vestibule, and the vestibule opens up into the oval window. That is the stapes footplate. This is a basal turn of cochlea. That's the promontory. That's the round window over here. And that's the internal acoustic canal. That's the crista falciformis. That's the superior part and the inferior part. So this is the IAC complete anatomy. Then if we keep on going behind, this is a superior, that's the lateral semicircular canal, that's the tympanic membrane, you can see right there. What else we can see over here? So we can see the facial nerve. I can show you the facial nerve as well. We can easily see the facial nerve. That's the cochlea. So the moment you see, this is the malleus and the incus. This is the malleus. This is the incus basically, and the stapedial area. So the moment you see the ossicles, you can see the basal turn and the turns of the cochlea over here. And what you can see over here a little bit, you can see a snake eye appearance. These are the two dots over here. These two dots represent the facial nerve. Now both of these are facial nerve. The one behind, or you can see the medial aspect. On the medial aspect is the labyrinthine segment of the facial nerve, and the one on the lateral aspect is the tympanic segment of the facial nerve. So if you can just follow this segment over here, that's the tympanic segment of the facial nerve. This is the facial nerve. So this is the lateral semicircular canal, and I've been saying this repeatedly again and again, that this is the facial nerve, and the facial nerve runs below the lateral semicircular canal, right? This is the lateral semicircular canal, and this is the facial canal, the facial nerve running below it. So if we keep on following the facial nerve, this is the facial nerve, you can see the facial nerve right there, and then this is the facial nerve, this is a facial nerve, and you can keep on following that. You can see this is a vertical segment of the facial nerve. That's the vertical segment of the facial nerve. If we keep on following that, you can see that is the exit point of the facial nerve. That's the stylomastoid foramen. This is mastoid, this is mastoid tip, this is stylomastoid foramen, and this is how the facial nerve exits outside. So if you keep on following it behind, the facial nerve is now gone. This is how you basically, this is basically the posterior semicircular canal on the coronal view basically. Now this may give you a glimpse of the false assumption of that being a superior semicircular canal, but this is supposed to be the posterior semicircular canal, okay, on the coronal view. So this is how you basically view the structures on the coronal scan. Okay, so this is how you can see structures on the coronal scan. You can at the same time compare the axial and the coronal. So this is how you should basically read the CT scan. If you have any doubts, you can take a CT scan of a normal patient, take the CT scan of a diseased patient, or you can just take the same patient and compare on the right and the left side to know the anatomy much better. So this is how you should read a scan. So any doubts in this video, if you feel, you can comment on the section below, and I'll be happy to reply to all your doubts. Okay, thank you so much.